Hi, everyone. I'm Mark Plaster,
And I'm JD Landon.
and this is EP Talk, the place where EPs, emergency physicians, come to talk about things that are important to us, sometimes professional, sometimes personal, but just anything and everything. And JD is my sometimes co-host. He's still working more than I am. You can see that I'm relaxing. I'm actually aboard Dawn Treader in Oxford, Maryland, our sailboat, and I get to play while he has to work. So I'm going to pick his brain today. We've been talking in past podcasts about a lot about ultrasound. He just finished his ultrasound fellowship, and so I've asked him to pick out some specific applications and to kind of walk us through it. And so this podcast is dedicated to that. One of those skill sets. So I'm going to kind of turn it over to you, JD, and I think you're going to share your screen and take it from there. And then my dumb comments will come in on top of that and questions when I don't understand what you're doing. Okay.
Yeah, so we're going to talk about a nerve block today. Now, I think nerve blocks are super fun application for ultrasound. It's a way for us to kind of use those procedural skills, right? I mean, all EP docs, right? When we made that decision to go into emergency medicine specifically, we're like, we love procedures, right? We always love procedures. And so we're like, anything we can like stop writing notes and actually do something with our hands, right? We're like super stoked about it. So I think the Erector Spinae Plane Block is what we're going to cover today. ESP, you might hear me refer to it. It's a relatively new nerve block within emergency medicine. We're talking probably in the past 5-6 years. There's probably some forerunner fringe guys who've been doing this for 10 years who might write us and be like, I've been doing this for 20 years. I'm sure those guys are out there. Kudos to you guys. But it's a nerve block that has lots of applications. We're going to start with a couple of them. So the primary reasons that we're going to do this is going to be rib fractures or spine fractures. I love this block. First time I did this block was like an 83-year-old lady, right? We see these people all the time, ground level fall, fell backwards and just kind of zipped her ribs, like 5-6 ribs.
Ouch.
And of course, so now we have like moaning Myrtle in our ER.
Right.
And everybody's looking at you. Whose patient is that? Shut her up.
Yeah.
And one dose of pain medication doesn't touch it. Two doses of pain medications.
Or you knock them out and they little old ladies. You knock them out. They don't breathe for 3 days.
Right. So that's
and this would actually make matters worse because they're not breathing.
Right. So the second pain dose medication, they're like, moaning Myrtle's not moaning anymore.
It's also an agonal breathing.
Right. Okay. So we've all had these cases, right? We're like, they're still in tons of pain, but now you're either like, we're either going to intubate this lady or we're gonna try something else. Right. And so this is where the ESP block is just gold, right? Just complete gold. Real quick, a couple other indications that people are doing this for. Actually, was just a part of a case series we published on renal colic. Right, so we did the ESP block and saw nearly complete resolution of pain in renal colic. We're working on trying to do an actual more randomized study to actually look at whether we're seeing a significant decrease in opioid use, a couple other things. The other thing that I love it for, and actually one of the earliest indications, is actually zoster or burns. Right, it's like burn pain, super hard to get control of, and that kind of neuralgia, neuropathic pain is a great block for.
Oh, I tell you, zoster. I had zoster a couple of years ago, and I honestly, my wife thought I was the biggest pansy in the world because I only had like 3 blisters on my back. Okay. And I was in absolute agony, and I was unashamed to write myself narcotics. And I'm sure if the Board of Medicine ever found out all the narcotics I wrote for myself or wrote for her, and I took them, we'd be in a lot of trouble. But it was horrible. It was absolutely horrible. I would have taken a nerve block in a heartbeat.
Right. Yeah. Anybody comes in with bad shingles, they're like, yeah, okay, where do I sign? No problem.
Yeah, exactly right, man.
Some of the other wild things that I have not used this for, but there are reports that it's been effective in, is pancreatitis, which I think is fascinating. And so we'll get into some of the kind of neural pathways and why this block works. But those are some of the indications. So let's jump over here. Let me just change my screen, and we're going to talk about some anatomy real quick. All right, let's see if this is going to work. Okay.
Oh, man.
So Sorry, there's a lot going on this screen, but we've got two views right here. We've got this view over here, which is this a picture of the spine, right? And so here's your vertebral column. You can see here's your spinous process here, your
Okay.
transverse process. Now,
Okay.
the goal with this block is getting our anesthetic right into this little groove here between your transverse process and your spinous process. Can you kind of see this space here?
Yeah. Yeah.
Um,
Okay.
Here's a cut, right? So like an axial view here. So looking at our muscles here, right? On the most superficial, we've got
Okay.
our trapezius muscle, right?
Okay.
Just deep to that is our rhomboid, so our rhomboid muscle, major muscle, and then erector spinae muscle, right? So this is where we get the name. This erector spinae, which if you can imagine, if you remember from anatomy, right, it goes all the way up and down your spinal column, and that
Sure.
helps you stay erect. Something we all want to stay erect. So
Some
sorry.
more than others.
So so if you see here in this axial view, what we've got here, right? You got your spinal cord, you got your spinal root, and then here you've got your sympathetic ganglion here, and then you've got your dorsal rami and your ventral rami, right? So this is going to be feeding your intercostal nerves, right? The
Right.
nerves that are supplying all of your ribs, right? Wrapping around. And
Right.
we're just dumping a lot of anesthetic in this whole space. Now, the idea, we call this a plane block. The idea is that we're putting it just under the fascia of the erector spinae muscle belly, right? So you got this big
Gotcha.
erector spinae muscle, and we're going just deep to the fascia. The reason that matters is that if you can get just deep to that fascia, what cadaver studies, I'm going to show you a cadaver study here in a second, is that what they've seen is that anesthetic goes up and down along
Okay.
that kind of paravertebral space, like
Right.
4, 5, 6 levels,
It's almost like an
which
epidural.
exactly same exact idea, but we're just not messing around with the spinal cord here because as you can see the angle we're going right we're really quite protected from actually getting
Yeah. Yeah. Yeah.
any concern for spinal cord injury here.
Yeah.
And really, like, there's no crazy massive terrible blood vessels back here coming in through here through the muscle that we have to worry about either. So as far as safety goes, it's a shockingly safe of the nerve blocks. It's a pretty safe one. Okay, so let's go here to our next guy. Want to just cover real quick. I don't want to bore anybody too much, but we use ropivacaine in our shop. So this is
You,
just
you
like
might need you might need to interpret that because I think on the screen it's not very sharp. I can't read
oh,
those.
you can't see that.
Yeah, I mean,
Okay.
so just tell us what you're using there.
Yeah, so this is showing a chart and concentration and max doses. I'll make sure we put this in the show notes for everybody. So
Okay.
ropivacaine, usually it's coming in either 0.2 up to 1.0% concentration,
Okay.
right? And the max dose for ropivacaine, you just got to remember, is 3 milligrams per kilogram.
Oh,
What I just always remember is that as long as they are over 50 kilograms, right? So here's the 50. I come down in our shop, we're usually using the zero point 0.5. I can give 30 mils. And our
wow.
kind of pre-filled syringe has 30 mils of Ropiv in it. I'll show you what we use in our shop here in a second. And so that's kind of my general rule. As long as it's like not a tiny kid or a super cachectic person, I can give that entire syringe that I'm going to show you here in a second, this guy, and not have any worry about having local anesthetic systemic
And
toxicity.
that's saying RECK, RECK.
Correct. Yeah. So this is a product put out by this Cuva company. We were at my shops. We're just lucky enough that for whatever reason the hospital system's like, yeah, we'll stock this in the Pyxis, and so it's amazing. I mean, I can get this, to the bedside in 3 minutes. It's not a huge wait from pharmacy, but this is this one product. It combines ropivacaine, epinephrine, clonidine, and ketorolac. There's
Okay.
varying level of evidence of the benefit of those. I think this product was actually specifically built for outpatient orthopedic teams, doing kind of like joint injection type stuff. But it's been amazing. We love it. We don't have to do any fancy mixing. It's simple. You literally just pull it from the pharmacy and just use this one vial. So that's what we're using. You can use lidocaine if you want a shorter acting. The ropivacaine is longer acting, which is why we like it.
Mhm.
We
How long
prefer.
can you expect it to work?
So the couple studies that I've looked at it for fascia iliaca blocks specifically, um, almost like 95% of people are getting 6 hours of coverage. It drops down to probably between 30 and 50% of patients are getting up to 24 hours of benefit.
Yeah. Okay.
A lot of people will add in some Decadron, and Decadron also can extend the life of your block. All right, let's go here. So this is that cadaver study, super interesting study. So basically, they dumped. You can see my cursor, right, Mark?
Right. Mm-hmm.
Here, yeah. So they did the block right about here, and then so right about in line here, and then basically on one side, right, they saw their ink, which was simulating the lidocaine or the ropivacaine. They had it come all the way up as high, C2 to C5, and all the way down here into the lumbar on both sides, right? You're
not having to inject multiple times. You're putting in one place and it's going everywhere.
One place, large volume, one stick, super fast, and that's why we think that you can hit stuff like renal colic or hit stuff for pancreatitis. Is that kind of going along that sheath or that fascial layer. So here's a little animation here. So what we're going to be looking for here is the way we're going to physically do this is we're going to have your linear or curvilinear probe, depending on the body habitus, and you're going to have it in an up and down position, right? So or a longitudinal view here, or sagittal. And you're going to basically start out a little bit lateral. I use the tip of the scapula as my landmark. Alternatively, you can just use the ultrasound and run up and basically look at rib 1 and count down to about T6, T7. But typically, it's going to end up being around the spine, the tail of the scapula. Find your rib, and then you're going to, once you find the rib and you see the pleura moving, sliding underneath the rib, you're going to then slide medial until you see rib turn into transverse process, and it's going to be clear as day. I promise. It's surprisingly straightforward. So we'll keep on going with this. So that's what this animation showed you, right? So we start lateral, and then we slide medial until you see this transverse process come into view. Okay, so this is what it's going to look like here. I think it's going to switch over. Okay, so I'm going to stop it. So you see how this is real rounded?
Mm-hmm. Okay.
So that's your rib, right? Okay. Rounded ribs. Here's going to be our pleural line, and then you're going to watch it's going to slide medial, and it's going to turn into a flat. Okay. Did you see how this turned flat? Here, we'll go back and
where the tip of the rib did.
Exactly. So you're actually going to see it go from rounded, boom, flat.
Okay.
That's the transverse process. That's how we identify our landmark.
Okay.
One more time. Rounded rib, and you're going to see it actually slides. It's actually not there. It's over here, right? So it's not the same bone. It's not connected, and that's your transverse process. And you can also feel reassured is that you actually see the pleural line, right? Initially you see it clearly, and then now it just turns into this fuzz, right? And the reality is that's because this is not lung anymore.
Go back again and do that one more time.
Yeah.
Show me the pleura. Okay.
Lung, right? Do you see how it's not pleura anymore? You see how it changes?
Yeah.
Pleura, nope, gone.
Got it.
And now I've got a couple more images for us to look at, but our aim is going to be right at this corner is where we want to drop our needle. So we want our needle to come through the skin and then boom, hit right at the corner. And the reason we try to aim for the corner is the easiest spot to elevate that fascia off of the transverse process, right? So up here is our erector spinae, and there's a layer of fascia here, and ideally we want to elevate it off the corner or the tip of the transverse process so that it runs all along the spaces. All right, so I think that's it for here. Let's go. So we'll stop here for a second. So here, Mark, I know you always want to talk about like what am I doing with my hands, right? Like what am I actually physically doing? And here's a nice picture. There's two ways to do this. I'm not going to bore everybody with all the details. We can put a link to details of all the specific materials you need. Mm-hmm. But for today, we'll just kind of run through the basics of the procedure. But sterile probe cover is reasonable. Clean the area, plus minus sterile gloves. but you're basically right. So you're holding your, hopefully, if you can, if the body habitus isn't too tough, you've got a linear probe, your sagittal view, so up and down, and depending on your own ergonomics, you can either come from up here superiorly or caudally or inferiorly. So if it's more comfortable for you to hold it and actually inject from the bottom, that's fine. Doesn't matter. As long as you know which side your needle is coming into the screen.
Okay.
So I'm a tall guy. I usually come superiorly. And that just ergonomically for me is just more comfortable. All right, so here we go. And this is coming from Duke. I want to give a shout out to all these guys. Duke Anesthesia and Pain Medicine, Regional Anesthesia. They've got phenomenal videos. Highly recommend if you guys want to look at more details. So this is from them. They do a really nice presentation here. So this is where, right, we're outlining the erector spine muscle. Here's that transverse process we talked about. And then here we're going to see the anatomy here. And so you can see, right, there's really no lung down here, and here's our needle coming in so this is from caudally, and they're going to try to hit right at that corner. And you'll see what they're going to do is they're going to hydrodissect a little bit. That's just putting a little, like, 1 cc of fluid in to see the needle tip. There's a little flash of air there.
Mm-hmm.
And then you see it's starting to elevate this whole layer off of the transverse process. You see it's starting to fill here.
So it's okay. So it's just laying there. It's not attached. It's just laying there.
Correct. Yeah. So we're trying to get.
It's a potential space.
Exactly. And so we're just trying to literally like open up that space, and you'll know because if you're in the right space, it should layer out like that, like horizontally. If you're in the muscle belly, it's just going to fill that one local spot in the muscle.
You'll create a cavity.
Exactly. And so that's the key thing you want to be able to see. I think I've got one more. Nope, that's it. So we'll just run through it one more time. Coming in. Other key things just for logistics, you're going to need a spinal needle usually for this. Okay. We usually use a 22 gauge. If your shop is really nice, you can try to convince them to pay the extra money for the fancy regional anesthesia needles that are that actually will respond to the ultrasounds better, and you can see them really clearly. Sometimes with the spinal needles, depending on your angle, sometimes you can have a little bit harder time seeing your actual needle tip.
Gotcha.
So that's the Erector Spinae Block.
Okay, I hope that this has at least given you the idea that, number one, it's doable. Okay, the landmarks, we do things that are a lot more difficult. Okay, this is a doable thing that actually has real benefit. Believe me, if you've ever had if you had shingles, you've had fractured ribs, and I mean, there's nothing worse than telling somebody, I've got good news and bad news. You got broken ribs, you'll live, but the bad news, they're going to hurt like hell, and it's going to take a long time. Okay. And the old idea of doing rib rib belts, we don't use rib belts. You know why? Because people get pneumonias and they die because you don't breathe deep enough. I'm going to give you this incentive spirometer, and every time you use it, it's going to hurt like hell. Okay, and but I want you to do it. But we're going to give you this acute phase. We're going to give you a block that's going to give you some real relief and get you through that first phase. You know. Who knows? Maybe you come back and we do the block again. But the point of it is that we can offer you some real relief. That's good news.
It's exciting, and I think that people are always surprised when it works, particularly the nurses. And then the other group that is always surprised is when the trauma team comes down. Yeah. But I will say at our shop, one of the people that really started pushing this aggressively was one of our trauma ICU fellows. And he just started, they had rib fractures everywhere in the trauma ICU, and he just started going around and just doing them on everybody. And everybody, their lead trauma doc ended up getting convinced, and now they're doing them somewhat regularly. And it's exciting. It's great for the patient. The other thing that I should mention, just from like a technicality, is right. It is a large volume block, like we covered in the concentration, and so. You always have to be mindful of LAST, right, or local anesthetic systemic toxicity. And so, technically, right, we should always be having these people hooked up to cardiac monitor, and we should technically always have these people in a place where you're only a couple steps away from intralipids, right? So worst case scenario, I've only heard of one case in our system of LAST, but they will have cardiovascular shock and they will potentially start seizing if they get LAST, and you want to be close to intralipids to be able to give that quickly and stop that.
Okay, that's a good caveat. I mean, we do things that have potential consequences, and it's good to know that.
It's pretty rare. I mean, it's a pretty rare. I mean, you think, I always, chuckle to myself, right? I mean, we're giving intravascular lidocaine as a drug intentionally.
Right.
And so, I mean, it's definitely got a very good safety profile, but it definitely happens, and we got to be aware of it, and we got to be, ready for it.
And it's not technique, you're saying. It's not a matter of putting it into the wrong space. It's a matter of the patient, or just you're not aware that you're putting it directly into the vascular space.
Right. So with any injection technique, right, you always pull back.
Sure.
Right. So you always aspirate first before you inject. And so none of our nerve blocks should you be injecting into the vasculature. And so you're always aspirating as just a part of your normal procedure, your normal process. And as long as you're doing your due diligence to double checking your concentration, your max doses, it's incredibly safe. If you're aspirating correctly and you're checking your concentration and max dose, the likelihood of you having LAST is super low. The one case that happened in our system was, unfortunate, right? Trauma patient was just covered in large lacerations, just covered, like head to toe, probably a dozen lacerations. And so, the interns were kind of going at it. They're like, we got to fix all these lacerations, right? Yep. One bottle of lidocaine gets used, second bottle of lidocaine gets used, third bottle of lidocaine gets used, right? Because they're just, got three probably trauma interns all like doing, working as fast as they can, suturing this guy up.
No individual guy overdosed him. They all overdosed him together. It was a team approach.
It was a
team approach. We're going to overdose him with a team.
And he had great analgesia for his sutures and then seized, right? And so, so it happens. And it's just one of those things where it's like one little mental check in your process when you're getting ready for your blocks. Just check. Most patients, the amount that you're going to need isn't going to come close to their max dosing. But just as a reminder, ropivacaine 3 milligrams per kilogram. For lidocaine with epinephrine, we can go up to 7.5 milligrams per kilogram, and you're good to go.
Okay. Fantastic. I've seen some shrapnel injuries in combat that you look at them, you got 20 of them, in somebody's back, and from a blast in some case. And you're right. You send some corpsman in, he's going to inject them all. That's what they do. They're going to inject them all. And if you could actually get anesthesia with just a block, then that'd be fantastic.
Yeah.
Very inspiring. Very inspiring. And so I hope if you've been watching this and it's kind of inspiring you to think about what you can do with regional blocks and using ultrasound to see exactly what you're doing, not laying all that into the belly of the erector spinae. You've learned something. So stay with us. There's more to come. Thanks for joining us.